What's up, team? Welcome. Happy Friday. Thank you all for joining us. We have a special guest with a really cool project. His name is Travis Sack. He is a legendary figure at UCSF, having joined as an intern and then has proceeding through the ranks as a resident and then as a fellow and in hematology oncology. And I don't know how he does a million and one things, but he's maintained the overlap of his original love, one of his original loves of clinical reasoning, with technology. And the technology dimension has evolved. He was here not too long ago, maybe less than a year ago, telling us about his amazing website and software that he developed for the CPC universe. And he's here with a little bit more news on that, and as it relates to a evolving and increasingly important topic. So Travis, I'll hand you the mic to share.
Thanks. Yeah, I appreciate it. Actually, so this is it's a correlated project, I suppose, but not directly related. But I think it's something we've all been thinking a lot about, and that is how does these new large language models, the most popular of which is something called GPT or ChatGPT or GPT-4, how well do they simulate diagnostic reasoning? They're not reasoning engines, but they often can do a pretty good job simulating it. There are a lot of actually ethical issues with that I think are important to explore. And the most important one that we've thought a lot about is the biases that might be built into these models based on the training data they use. And so we have a project. It's a collaboration, kind of cross-country collaboration with a group at MIT to evaluate the diagnostic reasoning capabilities and any potential biases that could be present in them in GPT-4 and others. So we've created a pretty complex schema, but I think I'll be very brief. We are using the same data set that I use for University CPC, which is the New England Journal Clinical Pathologic Conference, which I'm sure many of you might be familiar with. It's been published for almost 100 years. So a lot of good data about how experts kind of reason and challenging cases that present to them. So the goal, to be brief, is we are seeing how well GPT-4 does at this task, and we kind of want to get a sense from medical trainees how well we do at that task, right? That it's a lot different than the USMLE in a lot of ways. I know people may have read, well, it passes the USMLE. I think USMLE is a very challenging task for humans. It's actually easier for computers than you may imagine because it's much more structured than real life in a lot of ways. So it's a lot more about just pattern recognition in a very simplistic sense. So this is a much more challenging task for it. I think it's a more appropriate task to think about. And so the goal, what I'm asking for is volunteers from the diagnostic reasoning community who are willing to go through a few cases and give us their differential diagnosis. So we've set up kind of like what we're calling a couple human arms to the trial, where I'm gonna put a survey in. You fill out your survey about some basic background on your training, what level of training you're at, and then we're randomizing people to two groups. We recognize the CPC is very challenging, right? These are kind of zebras. These are not run-of-the-mill COPD. So we want to get a sense, not just can you do it without any help? So we are going to have that arm where basically you're not allowed any external resources, but that's not fair. That's not how we practice medicine in this day and age. And so the second arm will be access to up-to-date. So basically search for whatever you want, look through everything, take as long as you want and come up with the diagnosis. We are going to kind of restrict overall total internet use because I do think that these are rare enough cases that you might stumble on the actual case, right? It is publicly available. So those are the two arms to the trial. We have funding from, so I don't know if you saw, but Zach Kohani is one of the guys who kind of like got early access. He's a professor at Harvard Medical School on how GPT-4 could be used for both medical education and healthcare. So we have funding from him for gift cards for people who get to complete it. You can share the survey. I think we're happy for anyone who's willing to contribute, and I felt like it was very on topic because it's basically kind of a few reps based on published data that people can go through. My email is always open for any questions, but I appreciate Robbie you having me on and pitching this.
So exciting. Do you want to drop your email and the link in the chat? And
Yeah, so I'll actually drop a survey, if that's okay, but I'll also drop my email. The survey, we'll send to my email, and then we can kind of collect and randomize is the idea.
that sounds awesome.
Yeah.
Fantastic. We'll try to share it as much as
And
we
honestly, like, I love talking to people about all these things, so email me about anything else as well. I'm happy to talk.
Amazing. You're the best. Thank you so much for hopping on and
Yeah.
for plugging this. And yeah, I think you found yourself amongst a crowd who love to do cases on their
Yeah.
own time as they are here, let alone to be able to contribute to a really important question. So I'm sure
Yeah,
that
and we recognize that. So in the task, there will be a marker for have you seen this case before? Because we want to be as scientific as possible. So you do the case, but if you've seen it before, we need to know that because we know a lot of you might have seen these.
Awesome. Well, it's really great to see you. Thank you for your constant pioneering work. And I look forward to the update on how this goes. Thanks for hanging out. Awesome. All right, y'all. We'll pivot to the case, and it'll be a quick pivot because another VMR legend is here and has been joining for with some regularity after a very busy intern and much of our 2 year. Andrew, hello. Nice to see you.
Hey everybody, just glad to have not been called in on my Jeopardy block this morning. I'm enjoying enjoying my day. Good to see so many friendly diagnosticians here. I have a good case for you, whether it's morning or noon. I hope you enjoy it. Do you want to get started, Robbie?
Yeah, let's rock and roll.
Okay, I'm gonna start with something short. So
Okay.
this is a man in his, oops, let me hold on, the full screen always pops up. Okay, this is a man in his 40s who presented with new right leg pain, making it difficult to walk. And I'll just stop there.
Fascinating. Absolutely fascinating. I think I'm really, since there are a lot of people, a lot of videos on, I would love to get the input of a CP Solvers team member here with their video, and not to call on people who may not have been a prominent part of VMR. So Deborah, I just see you're the top video I see. I'm curious what thoughts crossed your mind just hearing this.
Yeah, I think like I was thinking like it is new, so it's something acute. If the how started, what was the patient doing, like if was any movement, if was doing sport, or if was just walking, how that happened. And I can think about the area, like if it's something the muscle in the nerve, if it's something the bone. And I would ask how is the pain, like 1 and 2, 10, how the patient can tell me how is that pain. I think that's where I would start.
Yeah, I completely agree with you. I think that the categories that you just mentioned are very helpful to apply for any complaint in an extremity. Is it a skin issue? Is it a vessel issue like artery, vein, or lymph? Is it osteoarticular? So is it bone and joints? And is it neuromuscular, nerves and muscles? And so it's unusual for a skin problem to have prominence with walking. However, the other 3 strategies, vascular, peripheral arterial disease is a great example, neuromuscular, so patients with weakness may have difficulty walking, and then osteoarticular, if you have a bone or joint issue, that would definitely cause difficulty walking. The interesting thing is, if you're looking at just those 3 categories, so you start off with it's an extremity, so it's skin, neuromuscular, osteoarticular, or vascular. You eliminate skin because of the difficulty walking, then you're left with 3 things. Is it an osteoarticular issue, a neuromuscular issue, or a vascular issue? And the truth is, it's very, very unusual for neuromuscular issues to be unilateral and cause pain. They're usually bilateral. So the immediate reflex is this a vascular issue or is this an osteoarticular issue? And I say that because the most powerful thing is to immediately start to look at the extremity to figure out, is it actually a bone or joint issue or is it a vessel issue? And once you do that, then you can start to ask the right questions. So if you examine this patient and you see that he has a massive knee effusion, then your questions are going to be much more guided. If you examine this patient and see that he has no popliteal and a dorsalis pedis pulse, your questions are going to be very different. So in real life, when I'm seeing these patients, which is not uncommon where I work, I will actually immediately jump to the exam. And my question will be, oh, I'm so sorry, your right leg is hurting you. Can I please take a look? And then continue to get the history as I find out what other data we have. All right, Andrew, I know you may not have prepared it in that manner, so feel free to guide us in whatever way you like.
Yeah, absolutely. No, I think that's a beautiful framework to kind of start with this case. So, the next aliquot, he was in his usual state of health until about 1 week ago when he had a mild sore throat and sinus congestion. He had intermittent low volume loose stools, last episode being the day of presentation. Both his upper respiratory congestion and loose stools were actually improving. However, over the past 3 days, he developed this right leg pain. It was initially cramping in nature and then it actually spread to his left leg the day of presentation. His right leg symptoms are now notable for extreme right leg and foot pain, precluding walking. He's been recently clearing an outdoor lot with plans to build a house. He states he possibly had a tick exposure. By the time he makes it to the ED, he is having new myalgias of the bilateral arms as well. He has a past medical history only of hypertension. He doesn't take any meds. He has no allergies. He doesn't use any drugs, and he has no history of surgeries. That's aliquot number 2.
Amazing. I see, Josh, you're putting your thoughts in the chat. You want to share them out loud? Where'd your head go?
This is like, I want to acknowledge my like type 1 thinking that
Yeah,
like
yeah.
hearing this information is like, first thing I want to rule out is like, is this hypokalemia leading to this, myalgia or cramps that he's having? And then, especially after a diarrheal illness. And the other thing is, could this all be a viral syndrome? And then that could have led to a secondary transverse myelitis.
Yeah, no, absolutely. I think that it's hard not to hear all that data and think, hey, does he have a viral syndrome NOS? Because it's so diffuse. He's got cough, rhinorrhea, diarrhea. They're all very common as a URI. And I think the problem with URIs is a problem that we see with base rate in general. Whenever something is common and it is featuring in your clinical syndrome, it's so common that it's so common that it's almost impossible, at least initially, not to use it as part of the diagnostic thinking. But the opposite problem is also true. It's so common that it may just be an innocent bystander. How often, if I get a diarrheal illness, I will almost certainly blame it on the salad that I ate because I eat the salad every day. And one day I'll just think that it's the bad salad. And so here URIs are so common that you are often left wondering, is this syndrome related to a URI or is it not? So this is what we call the double-edged sword of the base rate. Common things are common, so they happen commonly. But common things can be so common that they can happen commonly in the background of an otherwise independently evolving story. And so how do you actually solve that tension in real life? I think you have to analyze the problem that's happening before you now, independent of something that's common, and then see if you come to a conclusion in which you can link them. What's the most common way this happens in my life? Somebody with a history of COPD comes in short of breath. Do we diagnose them with COPD exacerbation right away? No. We first say, I know COPD exacerbations are the most common cause of shortness of breath in a patient with COPD, but base rate is a double-edged sword. It's equally probable at this juncture that their COPD is true and unrelated, and they have heart failure, they have an MI, they have a pneumonia, so on. And so that's what I would be doing in this exercise. And I think the question is, what does the additional history tell us? And the additional history now ups the ante. It ups the ante because now every extremity is involved. So if we are now thinking skin, osteoarticular, neuromuscular, and vascular, which one of those categories is more likely to involve all the extremities? And I think it would be very unusual for an abrupt onset vascular issue to affect all extremities. So from this perspective, that's less likely. A skin process, you can have a diffuse painful rash for sure. You can have multifocal septic arthritis for the osteoarticular, and neuromuscular, gosh, patients with their myalgias from COVID, for example, all their extremities hurt. So from the perspective now that we're seeing this clinical syndrome evolve, I think the only thing you can say with a little bit more confidence is the probability of a vascular catastrophe is lower. So we're still on the hunt for which of those 4 categories is at play. It is still remains true that the extremity exam will be very, very helpful, but I think we have to be open to the following realization. Most extremity disease is limited to the extremity if it's just one. If my foot hurts, the disease probably just lives in my foot. Now that now that now that 4 different extremities have been invoked here, I think you have to be open to the possibility that there is a systemic disease. The notion that each leg is each extremity is affected independently is very, very tough to argue with. So where am I at? I think vascular is unlikely in this patient in large part because of 2 reasons. One, how quick this is evolving and how extensive it is. And I'd be really curious what the exam is to help us put it in one of the 3 remaining categories, but could a vascular process be here? Yeah, for sure. It's just, I think, much less likely than the other ones. All right, Andrew, tell us more.
Okay, I love this so much. You got it. So for his presenting vital signs, it was a temperature of 102.7, a heart rate of 120s, blood pressure 90s over 60s, breathing at 22, and he was saturating 99% on room air. However, pretty early into the presentation, like less than an hour, when you walk in the room, he's tachycardic to the 180s. His blood pressure is 80s over 50s. He's more tachypnic, and he's now saturating less than 90% on room air. And when you examine him, he's anxious, lethargic, and confused. His lungs are clear. He's tachycardic without murmurs. His abdomen is not rigid. And he has diffuse modeling of the skin, some trace edema. He has what looks like a right lateral heel nodule that appears kind of bluish underneath the skin. And there's an EKG that just shows sinus tachycardia, no ischemic changes. And the ED performs a POCUS showing a ejection fraction of 30% with global hypokinesis, no signs of tamponade or right heart strain. And that's the end of this aliquot.
Oh my gosh. Ooh, this person is very, very ill. Very, very ill. Ibrahim, I see that you have your video on. Thank you. Where are your thoughts at now getting this data? What do you think?
Well, I think it's interesting that he definitely developed this after a viral infection. But with that being said, I feel that we probably should not rule out causes like vascular disease, especially that he seems to have a systemic involvement. And then the patient also appears to be febrile at the moment. So I wouldn't rule out infectious causes at all. Maybe he had an infection that still did not resolve out. Medication failure, I'd be thinking about at the moment. And then he's also hypotensive. So I'd probably think about resolving that at the moment prior to further, for taking further history and looking into their case specifically.
Absolutely superb, my friend. I think you were upping the ante about how acute this is. We were saying, oh, if you measured your own pulse at the beginning of this case, like, oh, 40, man, right leg pain. Now, my gosh, I think you should be more tachycardic than this person because of how critically ill they are. Their extremities are modeled, their blood pressure is low, they're tachycardic, they're febrile, they're very, very, very sick. So I think this is the time where, oh man, my dear friend Yusuf has his video off. I was going to come to him to teach us a little bit about how he might be managing this patient, because what would happen in real life, you wouldn't be thinking diagnostically, you would be thinking about how to manage this patient. So Ravi, are you in a place where you could unmute? I see that you're in the chat. I'm not sure if you can unmute, but if you can, oh, hello, you're in your library of libraries. How are you today, Ravi?
Doing superb. Just a great case. Just
know,
going
right?
through from Andrew. Yeah.
That's it. Really, it's mesmerizing me so far. I'm really curious what advice you have for what you might think for management in this space, because I think your rapid response VMR and Yusuf's great work has made me realize that we should probably share these things more explicitly. I don't think I would be doing any management until I saw this stuff. So what would be crossing your mind treatment-wise?
That's an absolutely incredible question there. It's I think doing what you're doing, gathering the data there, but just coming through the alarming signs though, yes, the sinus tachycardia is a secondary phenomenon of what's happening, primarily borderline hypotension. So patients just hanging there off the edge there. There's no hypoxemia that I'm seeing. So At least the respiratory system, I wouldn't really bother with unless the patient does deteriorate. This diminished EF will make it problematic, say, in case the patient's blood pressure does drop. But we're definitely getting here a flavor of infection. Now, I don't know where the infection is, as you had remarkably gone through the possible causes, viral, bacterial. I don't know if this patient is immunocompromised, but do we have to entertain fungal or parasitic if the patient's come back from travel from somewhere? This mottled skin that are now typing in, definitely that can be a harbinger of an ominous finding. Livedo reticularis comes to mind. So the patient is definitely, I think, really going down a slippery slope, and I'm very worried. But as far as empiric management, I think for the infection, and I don't even know what we're treating, I would start with empiric antibiotics because we're dealing with borderline septic shock. For fluid management, we got to be really careful with the CF, but a patient with sepsis, you do need to give fluids, but you may have to be very ginger with the fluid. So giving small boluses if you want to maintain perfusion. We haven't gone to lactate, but I would draw a lactate to make sure the patient is perfusing adequately. And on the exam, I would want to know if the patient is warm or cold, because with this EF, you do have to think about cardiogenic shock. But pretty much is what I have to say there.
Absolutely superb. I love it. I think it's so wise. Yaz, I'll come to you in just a minute or two because I'll give you a minute or two to think about it. I'm going to share about something else, but you are my ID guru on this call, and I would love for you to tell us what you might consider for antibiotics for this person. I, in the meantime, will reflect on what Ravi just said, which is you have to assume this is you. My ID doctor in San Antonio. So I will I'll take a minute to reflect on the very complicated fluid management in this patient. And I think, Ravi, what you just outlined, I think, is the most important management problem in this situation, which is if you just assume this person's in shock physiology, there might not be in shock technically right now, but it's a good schema to start to predict what you want to do. You have option of distributive, cardiogenic, hypovolemic, and obstructive. The probability of an obstructive cause on day one, like a PE or a pericardial effusion, is low unless you get more data. So here, the tension is really primarily between distributive with sepsis physiology and cardiogenic. Of course, in this patient, he probably has some hypovolemic component given how sick he is, but that we usually is rarely a major contributor in somebody without massive fluid loss. So if he is septic, the two main considerations are, is he septic or cardiogenic? And my first piece of advice is forget the or here. He could be both. There's no reason he could have a profound reduction in his cardiac output and a profound vasodilatory state. They could be they're not mutually exclusive. But you may immediately dismiss the idea of a significant contribution of cardiogenic shock to this case by looking at how excellent his lungs are. And that's a very good rule of thumb. If you are invoking cardiogenic shock, in most people, they have left-sided predominant cardiogenic shock. And so as a result, they'll have pulmonary congestion. So you might say, wait, hold on. He's basically hypotensive, tachycardic, and his lungs are perfect. How could he have cardiogenic shock? So this is the instance where patients with abrupt onset biventricular failure or right-sided predominant failure can have florid cardiogenic shock with relative sparing of their lungs. Why? The extremities are modeled because they're not getting perfused, and the lungs might be modeled because they're not getting perfused. So here, my main DDX is, does he have profound septic shock with subsequent cardiotoxicity and cardiomyopathy of sepsis? Or does he have intrinsic involvement of the right side and left side simultaneously causing cardiogenic shock? And so what I would do in terms of fluid management for this patient is, before I decided on fluids, I think a fluid trial, if you were more sick, if you were more hypotensive and more symptomatic, is not a bad idea. But I may change my mind if I laid eyes on him and felt that he was more symptomatic, in which case a fluid trial is very helpful. But I think you can start to do your non-invasive fluid responsive measures, like elevating the legs and seeing the response. He's going to get an A line probably. He's going to get a central line probably, and measuring his central venous pressures and central venous oxygenation will be very helpful. And doing a point of care ultrasound to understand the status of his IVC and his assuming his right atrial pressure. So what's my biggest piece of advice? Simultaneous biventricular heart failure or right-sided predominant heart failure can really fool you because we're so used to seeing predominant pulmonary involvement as a result of disproportionate left-sided heart disease. So fluid management will be tricky in this patient. And if your hand is not forced by marked hypotension or signs of end organ injury, take the few minutes it does to understand the distinction and go from there. But I think antibiotics are certain in this patient. So Yaz, what did you come up with? What would you give this person?
Well, first of all, thank you for having me in this high state of like ID. I'm going to do my best, but as far as I remember from guidelines when we were studying with Dr. Ravi, is that in this patient with septic shock, first of all, there are certain levels, like you will want to start antibiotic therapy in 1 hour if it's like definitive empiric therapy, obviously, if in 1 hour, if you are certain that this patient has septic shock. If you are somewhat, some guidelines say like less than 3 hours, but you have to choose exactly which ones orienting in what could be the source of the infection. And even if there is in this patient, I don't think I know where the infection could be maybe from this nodule in his heel makes me think maybe he's wounded, maybe it's a soft tissue infection that went up. Anyways, in my opinion, I don't think I would say which one could be the source specifically. So I would start with coverage for staph aureus with Banco and maybe add some pseudomonal coverage. If there is somebody here that's already a resident and it's listening to me, and please feel free to tell me, dude, you're giving him too much antibiotics. But I would think staph aureus with Banco and then pseudomonal or maybe some extended range penicillin beta-lactamase inhibitor, I don't know, third generation cephalosporin. I would definitely think of maybe cefotaxime, ceftriaxone, Banco-Ceftra. But again, I am, oh, thank you, Yusuf. He's saying that study from this year show that we should think we would choose beta-lactam before Bank. But yeah, I think those will be the first ones. Banco, maybe a broader spectrum carbapenem, or even thinking that penicillin beta-lactamase or a third generation cephalosporin. Although the combination, I am not very sure which one I would choose.
You'll learn a lot from your ongoing experiences, but I think the premise that you're saying here, Yaz, which is that the patient is really sick. And so you should not try to be elegant with antibiotics here. I think you need to cover Staph aureus. I think you need broad gram-negative coverage, either with piperacillin tazobactam or cefepime or a carbapenem. And somebody who's so critically ill is a very wise idea. I have two pieces of advice that are nuanced. I think the first is that you should probably give this patient doxycycline, and we'll talk about that in a second. The other possibility really comes from studying what could this infection be. Whenever you can't find a source for an infection that isn't obvious to you, you should think of the possibility of bacteremia without a clear cause, and hence that the pyogenic antibiotics you mentioned. But could this be an infection that has resulted from his URI? And the answer may be absolutely yes. Could he have, for example, unfortunately for him, toxic shock from group A strep? He's sore throat, he's had sore throat, then when he gets diarrhea is your clue that might be happening. And so toxic shock syndrome is a very, very plausible diagnosis here, which would push you to consider clindamycin or linezolid. So what would I do in real life? I think I would probably give him Bank, give him piperacillin tazobactam, and give him clindamycin. And then the thought would cross my mind, wait, hold on, he's got tick exposures, he's got a heel nodule, could this be rickettsia? And depending on where he is in the United States, I'd probably also give him doxy too. So yeah, even though you were trying to be cautious with how much antibiotics to give him, I'd give him 4 different antibiotics. He's so sick. But yeah, Andrew, what'd you all do?
Wow, really thorough discussion, guys. I'm impressed. with your teamwork discussion, you pretty much landed the same thing that this patient ended up receiving. It was vanc, cefepime, doxycycline up front prior to hospital transfer, and aggressive IV fluids were given because the POCUS, there was no signs of obstructive shock on the POCUS, and the chest x-ray was actually pretty clear per a radiology read. So that's what was done up front. So I have all of the labs that were acquired prior to the frank hypotension. After the hypotension episode, a lactate was at 6.7, but everything I'm about to give you was like his presentation labs before he got super duper sick. So his white count was 12 with 11% bands. His hemoglobin was 13.8. His platelets were 100 with an elevated immature platelet fraction of 12.2%. He had a sodium of 133, K of 3.5, bicarb of 18, the GAP of 14, a BUN of 50, a creatinine of 4.36 with a normal baseline, an albumin of 2.9, a T-Billy of 2, AST of 180, ALT of 210, ALK Phos of 59. For coags, he had a dimer undetectably high, greater than 35, an INR of 1.97 elevated, and a PTT of 123 elevated. A mildly low fibrinogen of 113. And then for other labs, he had an LDH of 474 elevated, a CK of 2200, a CRP of 25, that's high sensitivity, and a high sensitivity troponin of 97. And he was subsequently intubated and required escalation to 3 pressors over the course of 5 hours, prompting transfer to our hospital. That's the end of this aliquot.
Oh my gosh. Oof. That sounds really, really bad. Really, really sick. Yu Ting, how are you thinking about this? What do you think of the labs?
Hi, can you hear me?
Yeah.
Yeah, hi. Yeah, oh my God, I don't know. It doesn't look that bad in general, like compared to how it feels, I mean, the physical exam. So yeah, I see some alteration, of course. Let me see. The white blood cell is high, and it doesn't look like he's anemic. And let me see, the creatinine, I mean, everything else, the chemistry doesn't look, I mean, that altered. That is my thought. I don't know, I was expecting to see more,
Yeah.
like more alteration.
Yeah, I think this case is tricky because if you just look at the thing, his white count isn't that high, his hemoglobin is normal, his platelets aren't too abnormal, they're low. But I think if you look at the pattern is really, really concerning because you see thrombocytopenia or a low platelet count, and then you see coagulopathy, elevated INR, elevated PTT, and that combination, along with a low fibrinogen, should have your operating hypothesis be that he has DIC or disseminated intravascular coagulation. And it's amazing how somebody with such overt DIC has only 12 white cells. But the alarm thing is that he has 11% bands. That is very, very concerning and very, very, very severe. And I think essentially with low platelet counts, coagulopathy, elevated D-dimer, and low fibrinogen, you've diagnosed DIC. And acute DIC is infectious DIC until proven otherwise. But unfortunately, I don't think he has just DIC alone, because with his mottled extremities, he has an extended form of DIC called purpura fulminans, which is when the DIC has gotten so bad that you start to form multithrombi acrally in your extremities. And so I think this case, quite honestly, becomes what are the acute causes of purpura fulminans? And especially in the context of a fever, most of them are infectious. A large fraction of them are gram-positive organisms like group A strep and Staph aureus. And in those cases, you might be lucky enough to culture it in the blood, but it's not uncommon for it to be a microscopic focus somewhere that you don't appreciate along the spectrum of toxic shock physiology. There's also a large number of gram-negative rods that can do this. And I think before vaccination for these two entities, type B Haemophilus influenza and Neisseria meningitidis, or invasive Neisseria species, are commonly implicated in this. But the gram-negative causes extend beyond those two organisms to include some esoteric things like capnocytophagia, which is usually associated with patients who have splenic issues or liver issues and who will have a dog exposure, which he doesn't seem to have. But let's not forget that there are also some atypical organisms that can do this, with rickettsial organisms being the champion cause of this phenomenon as atypical organisms. So I think I would now have my operating hypothesis be as simple, but unfortunately as complex as this. As simple as this is an acute onset purpura fulminans, prioritizing infectious causes of purpura fulminans. And so I think the probability would suggest that this patient has a pyogenic organism, staph, strep, Neisseria meningitidis, or Haemophilus influenza. And the one small thing you might do that's actionable is to query his vaccination history. Now, it sounds crazy. You're in the middle of ICU, you're putting in a central line, you're doing all this. But if you have access to that data, that might be pretty helpful, though in real life, you're going to be treating him for these things anyway. I'd be really curious to see what his blood cultures show. The only other arm to explore in addition to that is to say, let's get a good exposure history. Are there some exogenous organisms that we haven't thought of yet? And the only thing that I'm stretching my mind to think of is that list. Are there any exogenous organisms we haven't thought of yet? And you can get pretty fancy and esoteric thinking about much, much less common things that can cause somebody to be so healthy to show up to death's door in hours. And that list is a list of gram-negative rods from the environment that includes tularemia, that includes melioidosis as the main ones. But that's all. I mean, I think the antibiotics here is probably what you're going to lean in on. There's a role for heparin in early phases of DIC, though hem-onc consultation is often needed to help you figure out if this is well beyond that phase. And after that, it's really supportive care. Very, very sad evolution of the care. If I had to prioritize one thing now, I would probably be most worried about toxic shock from group A strep with purpura fulminans, given his pharyngitis presentation. All right, Andrew, tell us more.
Okay, this is the last aliquot before the final diagnosis. So some microbiology for you all. Because we live in the Northeast here, a Babesia smear was acquired. It's not very sensitive, so we ended up sending a PCR. It's still pending, but the smear was negative. Anaplasma and Ehrlichia PCR was negative. Legionella and strep pneumo urine antigen testing was negative. And by the time that he arrives to the hospital, we actually do have a preliminary result from 4 out of 4 blood culture bottles, preliminarily gram-positive cocci in pairs and chains. Imaging of the right ankle shows, this is X-ray, soft tissue swelling about the ankle, but no underlying osseous abnormalities and no sub-Q air to suggest necrotizing fasciitis. And next aliquot will reveal the final diagnosis.
Well, you know, I think, let me see what time it is. Andrew, I feel for you. I think taking care of a patient like this who's 40, who was fine, who's this sick, is really, really tricky. And I think we've been in our minds probably operating at warp speed after the first aliquot. And I think it's a good time now to just slow down and practice something a little bit more deliberately, which is how we approach this smear, this blood gram stain result, because I think that's going to be key. So let's be systematic about it. So we'll just start at the top. Deborah, what do you think of when you hear gram-positive organisms in the blood? What are the possibilities? Gram-positive in the blood. What do you think of?
Sorry, I was helping.
Oh, no problem. No problem at all. Yeah, no problem at all. I'm just curious to get your reflex, just your reflex. When you hear gram-positive in the blood, what are the possible organisms that your mind reflexively thinks of?
I guess, as it's cocci positive, maybe staph. I would think
Excellent.
about it.
Beautiful.
That would be my first thought.
Amazing. I think staph is probably the most important thought. Jess, any other bugs you want to add to the list? Gram-positive. If you just know it's gram-positive, you don't know cocci, we'll just try to make the whole list, and then we'll try to apply the other clues. So we got staph. Anything else that pops up to mind?
Could be if I'm not saying wrong, maybe Clostridium, I guess.
Yeah.
It's positive too.
Exactly. Clostridia, if it's just gram-positive, we're making a list for gram-positive, just to be clear for everybody listening. Staph, Clostridia. Any thoughts, Jess? What else would you add?
Me, Jess?
Sorry, Robbie, are you seeing?
Or
I'm
which
so
Jess?
sorry. How about this? How about Dr. Bajwa to make it a little bit easier?
Oh no, that's way too formal. I think I agree with everyone. So I would think Staphylococcus, Streptococcus. Strep has so many different variants. So you're
Yeah.
thinking of like Staphylococcus, epidermidis, auris, bovis,
Amazing.
Agalactia, all of that stuff. But I would agree with, I think someone else already mentioned it, but Clostridia perfringens is something that
Yeah.
I would also not want to miss.
Yeah, 100%. Ibrahim, any other organisms you want to throw on the list? I think there's been a comprehensive one, but I want to hear your voice before we move on. It's been too long.
Yeah, so honestly, I'd think first of MRSA as well as the Clostridium. I think of Clostridium perfringens probably due to their purpura dominance.
Yeah.
But then also I'd consider other organisms on the differential, especially, for example, if there was a history that would clue us into something else. So for example, if the patient presented with pneumonia first, I'd think about strep rather than staph. But yeah, I think the list is already pretty much comprehensive.
100%. Agreed. So let's just paint the picture. If you just know it's gram-positive, you only heard the first words from the micro lab. It could be staph, strep, it could be enterococcus. It could be a cousin of enterococcus, something called aerococcus. And then a long list of other organisms. And that long list is really the gram-positive rods. There are many more gram-positive rods than there are gram-positive cocci. And so the list of gram-positive rods reflexively is things like Listeria, Bacillus, Corynebacterium, Clostridium, Nocardia, Actinomycoses, Lactobacillus. There's a long list. So I can't tell you how profoundly helpful it is for you to hear cocci or rods. And here it's cocci. And then within cocci, you want to know, are they in clusters or chains? Clusters suggest Staph aureus or Aerococcus. Chains suggest Strep or Enterococcus. As a general rule of thumb, Enterococcus is usually not very virulent. It causes subacute bacteremia. Patients usually come in with a week or two of symptoms. It's very rarely this critical. So this patient, you see gram-positive cocci in chains. Strep versus Enterococcus, you'd probably lean strep. Within strep, there are three broad categories. There's the alpha, beta, and gamma hemolytic strep. And as a general rule of thumb, the beta hemolytic strep are the most virulent. Group A strep, group B strep, and then all the group streps. And so here, I think base rate would prioritize you saying that this is so logic would take you to strep, virulence would take you to the group streps, and then base rate would take you to group A strep. And then you would hammer it home as the leading cause by asking this one question: which one of the group streps make somebody who was previously healthy devastatingly ill? Group A strep. Group B strep almost always occurs either in young children or in patients with compromised immune systems as a result of diabetes or cirrhosis or things of that nature. So unfortunately, anyone is vulnerable to what happened to this person. You get a little bit of a sore throat from something else, and then group A strep causes devastation. Our beloved Prof. Rez has a case report written where somebody got neck fash after group A strep pharyngitis. So I think my working diagnosis would be that this patient has group A strep bacteremia with group A strep purpura fulminans, toxic shock, NOS. And unfortunately, the prognosis is not great at all. But I will pass the mic to Andrew to enlighten us. And I got to tell you, this has been a heck of a journey so far. So no matter what the conclusion is, we've learned a lot. But really excited for you to take over and land this plane.
Robbie, I just want to commend you on kind of creating the Venn diagrams for everyone very explicitly on kind of how to start with leg pain, shock, the positive blood cultures. You really have a nice Venn diagram in your head to visualize kind of what's going on with this person. And sure enough, the bullseye does, line up in the middle. You actually had aliquot number 3. We're kind of on to the syndrome in this young man with no past medical history and very, very rapid shock. What had happened is we had podiatry come and do like a debridement of the like lateral ankle lesion. that he had. It didn't have any frank pus inside of it, but they just debrided NOS. I'm not sure exactly what they did, and they took deep wound cultures of that. And that culture ended up matching the blood cultures for group A strep. So he was diagnosed with toxic shock syndrome from group A strep. And very, very, very humbling case. Definitely something that reminds you of your mortality. It makes you think this could kind of happen to any of us. It was extremely, extremely sad to see this. I'd never seen it before. It's something we all learn about in med school, but highly, highly classic in reflecting on the case. I'll get your reflections and everyone else's reflections, and then I just have a paragraph from a case series that talks a little bit about this. I'm happy to read off of in terms of teaching points. But first, I'd love to hear from you.
Yeah, no, Andrew, I think that I'm really, really grateful that you brought this case to us. And I think there's a lot of learning along the way. And I think it just is humbling to pay attention to all the features of this case. And I think the most noteworthy is how compressed it was. So many people end up in the ICU with this outcome, but usually it takes days or weeks, slowly worsening shock. The fact that this happened like this is the most specific feature of this case, I would argue. And so we don't get to talk about this very often. I'm really, really grateful that you brought it here today, and really grateful to your Jeopardy system not calling you in. Works out for everybody. I'm curious. It seems like the chat is curious as to know what happened to the patient. Do you mind telling us what happened and then what you learned?
Yeah, so he unfortunately ended up having, just as within the 6 hours of his presentation, continued to have rapidly escalating pressure requirements, and the ICU team ultimately ended up adding on a adjunctive treatment called methylene blue, which I had never seen before. And this is after I left the service. I only admitted him to the service. So I can't speak to methylene blue, but that's basically like a final line for septic shock, it seems. And they also ended up implementing IVIG, which seemed to temporarily turn his numbers around, but after that, the pressure requirements went the other way again. So unfortunately, from the onset, or rather the presentation time to the hospital to his passing, it was roughly 48 hours. So it's highly, highly dramatic, which is pretty typical based off of what I've read.
That's devastating. And yeah, unfortunately, this is not, yeah. And the crazy thing is there's not much you can do about it, like from the time that you start to even suspect it to the time of death. Yeah, you probably get 1 or 2 doses of antibiotics in. It's really, really sad. I've never seen this myself, but have come across cases in VMR and other spaces. So thank you for this space. Yeah, you had some wisdom to pass on. Please do.
Yeah, I think one way we can honor patients, who suffer from diseases like this is to, learn from their cases and teach about their case so that we can recognize things like this in the future. So this is from a case series. So classically for streptococcal toxic shock syndrome, there are 3 phases described. The first phase precedes the onset of severe hypotension by 24 to 48 hours with a severe flu-like illness characterized by high fever, myalgia, headaches, and chills. But you can also have nonspecific digestive symptoms such as nausea, vomiting, and diarrhea. Interestingly, he had several of those symptoms, if you recall, prior to his presentation before he decompensated. You can have delirium in roughly half of patients. Skin lesions may be present. And exam of the skin and soft tissues is essential in the initial evaluation. You want to look for tenderness, localized swelling, erythema, or violaceous bulli, such as those observed in neck fash. Desquamation of the skin is described, but not present in all cases. I think what was telling in this case that matches the literature is the soft tissues involved with the infections are usually very, very painful, described as hyperalgesia that you would see like in a neuropathy, and they're frequently disproportionately compared to findings on exam. They can be localized in a limb, but also in the abdomen, pelvis, or thorax. And the discrepancy between the intensity of the pain reported by the patient and the normal exam should basically alert the clinician for the possibility of streptococcal toxic shock, which is exactly how this patient presented, where he couldn't walk anymore on his leg, even though he had a very, very unimpressive skin lesion. It was excruciating and widespread within hours. So certainly it's something I'd never heard of and considered, and something we can all take away from this. But I think the syndrome of rapid distributive shock plus pain out of proportion to exam of the leg, kind of as you'd say in the abdomen, is something you can take away as a red flag finding for toxic shock syndrome from strep. And that's all I got for you all. Thanks for listening.
Andrew, that was absolutely superb. So your final message is so distilled and so clear. Even though you finished by saying that's all I got, I think often the shorter and the more crystallized the wisdom is, the more powerful it is, honestly. So thank you for doing that for us. And it's such a great takeaway. If somebody comes in and has a history of sore throat and cannot walk, you may be looking at somebody who looks fine right then and there, but might be at death's door in 2 days. And I think that's such a simple and powerful takeaway. Thank you for that. I will pass the mic to my dear friend Shema for the teaching points, but I apologize, Shema, in advance. I have rounds with my team at 4 minutes, so I actually have to step away to make it there on time. So I'll have to listen to your teaching points next time. So I will make you the host, dear Shema, so you can do the teaching points. Please make sure to end the meeting afterwards. Otherwise, we'll probably listen to all your private thoughts and reflections, which I have done many, many times.
Okay,
All right.
thank you.
Bye, guys.
Bye. So thank you so much, Andrew, for this very amazing case. So I would start with some quick teaching points. So first of all, we had leg pain as a chief complaint, and we learned to go through some categories. So is it the skin? Is it vascular, osteoarticular, or neuromuscular? And we also learned if it's bilateral, we usually think of neuromuscular. And we were also thinking if there is a diffuse involvement, we would rather think of a systemic process and not vascular, because in this case it was very rapid and extensive, why we didn't prioritize a vascular issue. But we also learned from the chat, sometimes you can also have a diffuse manifestation in a vascular disease if you have something like vasculitis. And then also the important thing in terms of leg pain, the past medical history is always important. So is there any sign of is he immunocompromised? Is there any joint replacement, sickle cell disease, the sexual history, any risk factors for DVT? And then again, the categories for shock, is it distributive, obstructive, cardiac, and hypovolemic? And then for cardiogenic shock, we learned usually it is left-sided predominant, and we would expect pulmonary congestion, but we also learned you can have sparing of the lungs if you have abrupt biventricular involvement or right-sided predominant involvement. So that can be sometimes very tricky. And then the management of septic shock, usually we contain some blood cultures, you give volume, and empiric broad spectrum IV antibiotics. And we learned this golden hour for the antibiotic therapy. And you would also give a central line, do POCUS to estimate the IVC. And for the coverage of the antibiotics, in this case, we would start with broad spectrum like pip/tuds to cover Pseudomonas, vancomycin for staph, and also clindamycin, especially for soft tissue involvement, and doxycycline if we have some atypical bacteria that are intracellular. And then the labs were very suggestive of DIC because we had low platelets, a coagulopathy, low fibrinogen, and elevated D-dimers. And if you have an acute DIC, we would prioritize usually infectious disease. And here in this case, we had acute purpura fulminans. So we were thinking of the ID spectrum. You think of gram-positives like group A strep or Staph aureus. And in the gram-negative category, you think of Haemophilus type B influenza, Neisseria meningitidis that can go in with Waterhouse-Friderichsen syndrome, and Capnocytophaga canimosus if you have something like a dog bite, and or rickettsia. And then the differentiation for the organisms, if we have gram-positive organisms in the blood, you have to ask yourself the question, is it in clusters or in chains? If it's in clusters, you think of staph or Aerococcus. If it's in chains, think of strep versus Enterococcus. And in strep, usually in this kind of case, rather beta hemolytic strep because they are more virulent. And in adults, we usually think of group A strep, and in children, group B strep. And the clue in this case was there was sore throat and also rapid onset of shock and also pain out of proportion. We learned to think of toxic shock syndrome due to strep. So thank you so much for this amazing case, Andrew. I learned so much.
Thank you, Shama. That was a really, really lovely summary. You're incredible. I really appreciate you being here and everyone else being here. I hope everyone has a good day. Take care.